So it's my great pleasure today to introduce you Dr. Heather Boris for today's seminar. Heather is a associate professor of pediatrics and practicing attending neonatologist at the Hospital of the University of Pennsylvania, as well as Children's Hospital of Philadelphia. She completed the MD at Temple University School of Medicine and did an MPH at Harvard School of Public Health. And she also completed the clinical fellowship and research fellowship at Boston Children's Hospital. She has dedicated her career to understanding racial and ethnic inequities in perinatal outcomes with the goal related to targeting effective public health policy and interventions to reduce harmful exposures that can cause preterm births, including air pollution and the lack of green space and many other social determinants of health. She is currently an MPI on an R1 grant to examine neighborhood green space, hypertensive disorders of pregnancy, chronic hypertension, and racial disparity in maternal morbidity. She has also led the GeoBirth cohort for preterm birth disparity research. Today, she will present us the findings from her research with the title Environmental Contributions to Perinatal Health Inequity. Heather, please.
Yeah, thank you so much for having me and inviting me this afternoon. I know there's some competing talks, including a wonderful women's defense. So for those of you who have already heard me talk, at least in the last 9 or 12 months, you've heard some of this before. So please tune into Alexa Woodward's defense instead. For the rest of you, thank you so much for having me. I look forward to hopefully engaging in a little bit of conversation toward the end. And feel free to, in the meantime, if you'd like to put comments in the chat, if I could just ask you to monitor the chat in case there's something that is worthy of interrupting me for, please do so.
Absolutely. I will.
Okay, fantastic. All right, let's see if I can get my slides to go. Yeah, so I don't have any disclosures. We have a little bit of funding for our research from various sources. And I like to start off with gratitude because by the end, I often forget and half the people are sleeping. And so I just want to make sure that you know that there's absolutely no way I could do all of this work by myself. And there's a huge team of really dedicated humans, and this probably doesn't even cover all of them, who have joined me in various ways or mentored me in various ways, or have been willing to have me be their mentor. And so it's been really a fun journey. I'm going to go through a little bit of my story just so you have a sense of getting to know me. Also, in case you'd ever like to collaborate and you want to reach out, I just want to give you a little sense and flavor of who I am. So that's me back in 1981 in first grade. I grew up in Bloomfield, Connecticut, which is a suburb right north of Hartford, Connecticut. And then I was a student athlete in high school. I played multiple sports, including soccer, which I also did when I was here at Penn as an undergrad. And I remember, I'm not very flexible, but I remember when I would stretch on the field, I would also look up and see the old Children's Hospital of Philadelphia and think, maybe one day I'll get to work there, which I've gotten to now twice. I went to Temple. I lived with my friend's mom in Society Hill to save money while I was like waiting tables down in on South Street. And I would ride my bike to Temple, which, as some of you know, is quite the bike ride through Northern Liberties and then through North Philadelphia and then up to what used to be just called Temple Medical School, but now is Lewis Katz School of Medicine. And I really, I think as I would ride my bike through this environment over and over again, you would just notice the gradations throughout the neighborhoods. And I think all of us that live in and around Philadelphia or any other big city can see variation in environments all around us. So I think that probably affected some of the choices I made going forward. So at Temple, there was also a big observation of lack of health equity. This was a lot earlier than kind of the more modern journey that lots of folks are on when it comes to health equity. And I think my career was motivated for my passion for caring for kids and their families, principles of justice, a fair amount of intellectual curiosity, as well as nerdiness. So when you combine all of those things, you end up doing some of the work that you'll see presented here. I do want to clear the air a little bit, pun intended, but around why I, as a white woman, might be talking about race, because this can get really uncomfortable really quickly, and we don't always do it well. I don't always do it well, and I think it's important for us to grow and learn together on how to do this better. I think it's reasonable to say, why is some white woman presenting about race? But it's also a privilege to not think about race, right? And so, in many of my day-to-day activities, I don't have to think about race, and so that's a privilege. But it's also a privilege to give invited talks, and so I'm encouraging us and in our research program to diversify the voices that we're hearing, and that's part of our work, is to improve the pipeline and to continue to collaborate with folks who can go ahead and give these talks instead of me. This work can be uncomfortable. I may mess up, but we really can't ignore race in the NICU. And I'm going to talk about that. When I say NICU, I mean neonatal intensive care unit, which is where I do my clinical work. And I want all of us to learn, evolve, and act. So the elephant in the room is that non-Hispanic Black infants disproportionately populate our NICUs across the United States. And this is largely due to differences in preterm birth rates. And it doesn't matter whether we're looking at preterm birth defined as less than 37 weeks gestation, looking at earlier preterm birth, whether you're looking at low birth weight, if you don't believe the gestational age on the birth certificate, or very low birth weight, there are disparities in each of these outcomes. And when we get to the sickest of our kids, the less than 28-week gestation infants, we see the largest disparity with a risk ratio of about 3.3. So Black infants are more than 3 times more likely to be born at the extreme low gestational ages. This is really striking when we think about all births in the United States. So if we look at all births in the United States, there are nearly 3-fold the number of births among white families compared to Black families, and yet they're nearly identical numbers of infants born less than 28 weeks. So the disparity is stark, and I'm not sharing anything new. This has been known for decades. I want to talk about what I'm talking about, which is race as a social construct. I'm not talking about genetic ancestry. I'm not talking about some sort of DNA sequence or anything like that. And I think one of the questions that comes up is, what does that mean? What do you mean by race as a social construct? We say it all the time, but what do we really, really mean? And what I would say is that race is entirely contextual, okay? There are ancestral places that our ancestors came from, but that's not the same as race. So any of you who have read or listened to Trevor Noah's book, Born a Crime, he has this incredibly interesting story he tells, where he's talking about apartheid in South Africa. And he's talking about how folks from China were considered Black within apartheid, whereas folks from Japan were considered white. And in the evenings, there was a time for a curfew. And so folks who were considered Black in South Africa had to be home at a certain hour, whereas white folks could stay outside. And so he tells this story about, a police officer walking up to a person sitting on a bench and going over to him and saying, "Sir, it's past curfew." And the gentleman responding, "Oh, I'm not Chinese, I'm Japanese." And then the officer saying, "Oh, I didn't mean to be racist. I'm sorry. Enjoy your evening." And so this is just such an example of how race is completely contextual and not having anything to do with some sort of underlying biology, especially in the case of curfew and sitting on a bench. There's also more genetic variation within than between groups. And so what we mean by that, this one's a hard one. And the way I've decided to conceptualize this is that if you think about something, pretend for a moment that height were completely genetic. It's not, but pretend for a moment it was. Say you could give everyone the exact same diet over generations and that height were completely, therefore, genetic. in that case, you would still end up in that population with outliers. You'd end up with people who are very, very short and very, very tall within populations. And so that difference would be a lot bigger than kind of the average height between populations. And this has been shown in things like birth weight when you look at the WHO's decision to use a growth standard instead of a growth reference, because when you optimize nutrition during pregnancy, for example, birth weights, for example, are very, very similar across populations. So this is an example of how we might think about there being more genetic variation within than between groups. This is different than continental ancestry, which I'm going to get back to in a second. And there's also been tons of admixture over generations. And especially here in the United States, we have so much mixture so that even when you think that you might, all of your ancestors may have come from one place, it may not always be the case. So why do we remain confused, right? And I think some of us still remain confused. I can confuse myself and trip myself up too. I think a lot of it has to do with the way that we're taught, at least in biology or in medicine, about, and maybe nursing and other fields, about some of the diseases that really do seem to track with race, right? So when we think about sickle cell disease, the single gene mutation, a point mutation in a specific gene, and it's way more common in folks that identify as Black or African American, and it's really way less common among white folks. And so the entirety of the disparity, the racial disparity or differences in proportion of folks with sickle cell disease by race is genetic. And that does happen. It happens for specific diseases that have a single gene mutation. But most of health and most of our disorders are not single gene mutations. They're really complex disorders. And so as we move across this continuum, you can end up with things like cancer. If you think about breast cancer for a moment, I'm half Ashkenazi Jewish, so I get asked all the time about my BRCA1 and mutation status, et cetera. But there are a lot of other reasons that I could get breast cancer, right? Like my drinking habit in college might have been a problem, depending on my diet now, right? Whether I breastfed my kids, there's about a zillion reasons that I could end up with breast cancer. And so the environmental contribution to whether I'm going to get breast cancer also starts to play a big role, especially since I happen to be BRCA1 mutation negative. Okay, so there are some differences in prevalences of certain of these cancers by ancestry, especially when there is a specific gene involved, but most of the time these are really complex heterogeneous phenotypes. When we move across the continuum, we end up with disorders that are very messy, right? And for those of us who take care of kids, or those of us who did, at least in pediatric residency, we know that asthma can have so many different phenotypes, right? There are some kids who seem to wheeze when they exercise, and other kids wheeze when they have some sort of environmental contamination of like a dusty environment or certain seasons, right? Those may be very, very different kind of phenotypes, and there might be very different reasons that kids end up with asthma. And so the environmental contribution to asthma is going to be a lot bigger than the genetic contribution, especially because we don't have great precision on that phenotype. And then when we move all the way to kind of where environment is going to, and I'm not talking about the cause of necessarily in these earlier ones, the cause of the actual disorder in one particular family. I'm talking about population level differences. But when we think about something like gun violence or plane crashes, those are entirely social, right? So if only wealthy white people are flying around in tiny little jets that crash all the time, only white people are going to die from that, right? That's entirely social. That is not genetic at all. And so I put preterm birth way over here. Are there some genes that may give folks a little predilection to a slightly shorter gestation, or in some families have more extreme preterm birth? Yes. And so I think I saw Dr. Strauss is on here. There's been a lot of work trying to find genetic contributions to preterm birth. But when we think about preterm birth as a phenotype, it's really messy, right? So there's spontaneous preterm birth when you come in with preterm labor. You could break your water. You could have preeclampsia that started really a lot earlier, and then somebody finally decides that you're going to need to give birth at 34 weeks to decrease the risk to the parent. You could be induced at 34 weeks because I need to treat you for your breast cancer, right? And so those are all reasons that a kid could be born at 34 weeks. And often epidemiologically, we lump all of those phenotypes into one particular bin. And I think that when you do that, you're talking about a really heterogeneous, complex phenotype in which the environment is going to play a lot bigger role. And I'm not the only one who has thought about it this way. This was a groundbreaking article from 1997 in which Jimmy Collins and Richard David in Illinois showed differing birth weights on the x-axis and proportion or percentage of births on the y-axis. And there are nearly overlapping distributions of birth weights among infants born to white birthing parents and infants born to Black birthing parents who they themselves had been born in Africa. So they had been here for less than a generation. Whereas there's a shift to the left, smaller babies born to Black individuals who had themselves been born in the US. So there was something about being Black in the US for more than a generation that was driving birth weights and lower birth weights, and genetics don't change that quickly. This has been replicated in a zillion studies, including this one in which instead of looking at birth weight distributions, Elo and Jen Culhane looked at preterm birth rates, and you can see lower preterm birth rates among foreign-born Black individuals. And you can see once they adjust for all your traditional confounding variables, that this protective factor of being foreign-born seemed to persist. Sometimes I get a little pushback on this and people say, oh, I don't know, this cardiovascular thing, like there are definitely genes that are more common among Black folks that may be involved in hypertension or glomerular filtration rates or et cetera. A lot of that work is confounded by social environment. So if you happen to carry a few ancestral markers of African ancestry, you also often are exposed to lots of different environments than white people, right? So you're often also self-identifying as Black, you're maybe living in segregated neighborhoods, even if you don't now, maybe you did as a kid, maybe there are all sorts of different exposures. And one of the analyses I like to point out happened pretty recently, and the cardiologists do lots of fancy trials and give them fancy names. This was the SPRINT trial of different ways in which you can manage hypertension. And they looked at tertiles of West African ancestry to look at the response to these different trials. And on the y-axis, you can see systolic blood pressure, and then years after, the trial being underway is on the x-axis. The different colors, the top colors there are the standard treatment, and then you have your intensive treatment on the bottom colors. And what you can see is that nearly overlapping responses to the medicines, regardless of West African ancestry. It was really which treatment group you were in that was driving your blood pressure difference, not your West African ancestry. And then the number of antihypertensive medicines necessary also had to do with the treatment arm you were in and not your ancestry. And when they looked at glomerular filtration rate, you can also see nearly overlapping distribution. So it's really, not that this kind of assumption, once you look in a randomized fashion, that the ancestry part is really not playing as much of a role as I think folks thought it was in the beginning. So I'm not going to go through each of these because they take a fair amount of time, but I think as physicians, we often think like we can do something about this, right? Maybe if it's not genetics, and I'm not going to go through why it's not education, smoking, and interpregnancy interval, but maybe folks are thinking, oh, maybe it has to do with prenatal care or the quality of healthcare. A person who came before me in my fellowship program is a leader at the CDC, Wanda Barfield. This is her fellowship project from back in the 90s. She was in the military. She is in the military. And she had access to a military data set. And in the military, all people get the same kind of access to prenatal care. So there isn't a racial disparity in access to care. And what she showed, these are risk ratios, Black-white risk ratios in moderately low birth weight and very low birth weight among Black folks compared to white folks in the civilian arena as well as in the military arena. And what you can see is while there may be a bit of an attenuation among military folks for moderately low birth weight, the disparity is still very stark and it really persists for very low birth weight. So she concluded from this that simply offering and having access to and receipt of prenatal care, universal prenatal care, isn't going to solve the problem. And we saw this in Massachusetts too. For those of you who know about Obamacare, prior to that, there was Romney Care in Massachusetts, and that was in 2006. It was a universal health care law. When you look here, are risk ratios of low birth weight in 2005 before universal health care, and then in 2015, well after universal health care, you see improvements in both groups. A lot of this had to do with differences in IVF practices, but nonetheless, you see that the risk ratio between Black and white folks remained elevated and the same. So from this, we started thinking, and we're not the only ones, but thinking about an expanded framework for why are there these big population differences in preterm birth risk. And a lot of folks have been thinking about these individual risk factors, microenvironmental factors, genetic factors. When I talk about the microenvironment, I'm talking about the things that an individual might be able to tweak, diet and smoking, those kinds of things. But really then looking at the macro environment and thinking about things that we don't have as much control over, right? The air we breathe, the water we drink, the metals that are in our pipes, other chemicals to which we're exposed in our food wrappers, et cetera, as well as our social environments at the neighborhood level, as also in the smaller community level as well. And so Michelle Hacker is an epidemiologist in Boston. I also came up with this conceptual framework where we think about racism as the upstream variable that can lead directly to income inequality, for sure has led to and continues to lead to residential segregation. Where we live and how much money we make determines where we educate our kids. But residential segregation can also lead to toxic environmental exposure differences. Income inequality and racism itself can lead to psychosocial stress. For those of you who do any kind of more basic science or biology, we know that our response to physical stressors is affected by our emotional state. So an example of this would be if you think about a virus as a physical environmental exposure. We know that Dr. Cohen has shown us that the more stress we have or the more sleep deprived we are, he's shown this in randomized studies of healthy volunteers. You keep them up all night and then expose them to the rhinovirus, they're more likely to contract the common cold, right? Our immune systems are different. This is why all of your students at the end of the semester get a cold, right? And so we know that we are more susceptible to physical environmental exposures when we have social adversity. And so what we think is that the combination of social and physical environmental exposures largely lead to the differences in birth outcomes. What we didn't have back then when we created this conceptual framework was thinking about the buffers, right? The positive environmental exposures that might help to mitigate some of the negative exposures that many folks have. So we're not the only ones who think about neighborhoods mattering for health across the street. And maybe there's some folks here from Drexel. Ana Diaz-Rue is really, I would call her the mother of this field in so many ways. And I hope she would take that as a compliment. She was in the forefront of thinking of environments as the reason for racial disparities, economic disparities in health, largely thinking about cardiovascular health, but lots of other health outcomes too. And this is her conceptual framework. And she did a study that I think many of us would have dreamed to have been able to do. I mean, she had this data set that had all the variables you'd ever want, right? So even after adjustment for age, education, occupation, which we almost never have, smoking, physical activity, hypertension, diabetes, cholesterol, we almost never have that in our data sets, BMI, and individual income, which we also have missing a lot. She was able to show that living in a disadvantaged neighborhood increased the odds of coronary heart disease, whether you were white or Black. And this was also another groundbreaking article. It came out in the early 2000s, over 20 years ago now. So I do like to make this a little hyper personal. I started personal, I'll continue. This is a Google image of where I live right outside of Philadelphia. You can see City Line Avenue there right near my house. It's that yellow diagonal line. My kids call that the Harry Potter Road because when you cross over, you go into a different world. So if you were to drive up my street, this is what you would see. And then when I drive to work, I drive through West Philadelphia, and this is what you would see. And there are probably a lot of positive things about this neighborhood too. Social cohesion, it's easy to walk places. There are a lot of good things potentially about a neighborhood like this, but there are also some things that are potentially harmful, including potentially differences in the amount of air pollution that is nearby, differences in infrastructure and metals that are leaking out of pipes or leaching out of pipes. There may be different access to healthy foods and food wrappers that may be containing some of the fast foods in the neighborhood. There's definitely differences in green space. I mean, you saw that even from the Google image view. And even when folks are walking, maybe there's less benefit when you're walking in polluted areas or dangerous areas for other reasons. There are also really big differences in the social exposures in these neighborhoods. So the graph in the middle shows job opportunities in Philadelphia over the last 30 plus years, growing in the suburban counties and dropping / remaining pretty stagnant in Philadelphia. And then I don't need to tell this crew about homicide rates, but they're higher in Philadelphia. So as Ayman mentioned, I'm interested in many things. I'm very promiscuous when it comes to my environmental exposures of interest. And one of them is air pollution. So air pollution is a mixture of lots of gases and particles and things that can affect our health. We focus on PM 2.5 for a few reasons. One is that it's often available, publicly available data that can be mined for the purposes of doing environmental epidemiologic studies. The other is that PM 2.5, what that means is it's smaller than 2.5 microns in diameter. So this is so small that when you breathe it in, it can just readily cross over the pulmonary epithelial barrier. So it can just get into your lungs and cross right into your bloodstream. And so I used to think that air pollution really mattered only for respiratory health. And I think that's a common misperception among lots of us when we're first starting out here. And it is true. It can be an airway irritant. It can certainly cause people to wheeze. It can affect lung disease for sure. And that's where you're going to get the biggest dose. But the lungs can only do so much in terms of clearing all of this. And so there are systemic effects of air pollution, especially PM 2.5, which is small enough to get into the bloodstream. So it can cause oxidative stress and inflammation. It's implicated in lots of complex multifactorial diseases like stroke, myocardial infarction, lung disease, as I mentioned, all cause mortality. And there's a fair amount of data now to suggest that it contributes to low birth weight and preterm birth. We have a disparity in air pollution exposure in this country. And I would actually point you to the follow-up article that came out in PNAS last week, also about what it would take for us to equalize in, air pollution exposure in every single city across the country, also in PNAS. But this was a study by Chris Tessum a few years ago, in which you can see on the x-axis time and on the y-axis PM 2.5 concentrations. And you can see for everyone here, it's going down over time, likely due to the Clean Air Act. But you can see there's still a pretty wide population disparity, with Black Americans being exposed to more PM 2.5 on average than white Americans. And so what this really ultimately comes down to is that Black folks are exposed to the levels that white folks were about 5 years ago. I collaborate with Dr. Alan Just, who's an environmental epidemiologist and exposure scientist at Mount Sinai in New York. He's moving, I think, to a new institution, but I'll let him share about that. And he is he's masterful at combining satellite data with ground level monitor data and other features of the environment in order to generate really beautiful predictions. It used to be at the 1.1 kilometer grid, which is what you can see here, but now he's gotten down to just point level estimates. And so he can do tiny buffers for PM 2.5 exposure. For those of you who are interested, I thought this was really cool. The way they do this is really they know the truth where there are monitors, but they don't know the truth where there are not monitors, right? We don't know the actual amount every single day. So what he does is they train the model. They pretend this one monitor A, they don't know the truth about monitor A, and they use all the other data to predict the truth at monitor A. And then they tweak their model to get it better and better to predict monitor A. And then they do that for all the monitors in the whole EPA data set. And they use boosting methods, machine learning methods, to get their predictions as good as they can get them. And then once their model is as good as it can get, then they predict the ground level air pollution where there are no monitors. And so that's how you end up with this kind of smooth surface. So there's been a lot of chatter in the last few years about redlining and historical residential segregation, as well as lack of government investment. This was during the Depression, where there were loans that went out to help people to avoid going into foreclosure on their mortgages. And what was done in the 1930s was really that even neighborhoods that were very similar socioeconomically, but only differed by race, neighborhoods neighborhoods that were mainly Black residents were not deemed favorable for lending. And so there was systematic disinvestment in those neighborhoods. There's been a fair amount of criticism of this literature recently, meaning that it's not like it only happened then, it's happening now in other ways. And so it's both the historic and the ongoing systematic and systemic racism and institutional racism, et cetera, that is continuing to lead to differences in health outcomes. But from the environmental perspective, there were certainly some repercussions when it came to zoning rules, right? And so certain areas were protected environmentally when there was a lot more investment in these areas. And so when we overlay Allen's air pollution map with the redlining map in Philadelphia, you can see that to this day, there are still higher levels of air pollution in the areas that were redlined. And when we look in the GeoBirth cohort, which is the birth cohort here in Philadelphia at Penn Medicine at both HUP and Pennsy, so Hospital of the University of Pennsylvania, Pennsylvania Hospital, this is these births make up a little over half of all of the births in Philly. So we get close to population level, not completely. As you might know, people in North Philly are more likely to give birth at Temple. There are other places where you can give birth. But if we look at just the Penn Medicine births, you can see that there are disparities in PM 2.5 exposure. And it's about a 1 standard deviation increment higher among Black folks compared to white folks. And when we looked to see if this was associated with preterm birth in our cohort, we didn't detect a significant association with all preterm birth, but we do see it when it comes to spontaneous preterm birth. So that's your rupture of membranes or preterm labor.
That was crazy. Not in here.
Just gonna mute that person. Okay. There we go. I'm a bossy muter. Okay. And then with respect to multivariable adjustment, we can see here that when we adjust for the variables listed below, that we do start to see an emergence of an association with all preterm birth, but it's really driven by the spontaneous preterm birth association. And when we restrict to just Black individuals in our cohort, we see a similar effect estimate such that we concluded that regardless of race or ethnicity, air pollution seemed to be associated with spontaneous preterm birth in this cohort. This always leads to the question as to how, why, what might lead to, like, why would environmental exposures, whether you're talking about air pollution or neighborhood deprivation or some other environmental exposure, how would this lead to disparities? And there are so many possible physiologic ways, and this is not an exhaustive list, but it's an example list, right? You can get hormonal differences, you could have oxidative stress, you could have inflammation and immunomodulation. I get the question all the time because I did epigenetic work for a while. Is it epigenetics? The answer is we don't know yet. And I'm going to focus for a minute on microbiota alterations. So this is a cautionary tale. And this was, this is the stuff you can't necessarily write in a paper, but it's fun to talk about, which is that fancy biomarkers do not prove biologic differences between racial groups. Okay. And so I think sometimes people will make that conclusion, but that's not necessarily the case. So I've been lucky enough to get to work with Dr. Elovitz, who is a maternal fetal medicine specialist at Penn, who's moving to Mount Sinai to become Dean of Women's Health. It's a big job. We're very excited for her. And she has been a master at enrolling prospective human cohorts, including a cohort she calls the Motherhood and Microbiome cohort, the M&M cohort. And she enrolled about 2,000 individuals, and she collected cervical vaginal samples from all of them. The sequencing of the vaginal microbiome was done by Jacques Ravel in Maryland, and then he used hierarchical clustering to generate profiles. So what I've learned about the microbiome is not as much as some of you would know, but you get a lot of data, right? So many data points, and you don't necessarily know what to do with all those data points. And so what I figured out is that you need to decrease the number of dimensions, or you need to create profiles or groups so that we can interpret the data, right? And that the way that people do that might vary depending on the scientific question they're asking. But the way that Jacques Ravel does it, he uses hierarchical clustering, and he generates these profiles, which he calls community state types. And there's one particular community state type, CST4, that is different from all the others. So community state type 4 is dominated by anaerobes. And it has very few lactobacillus compared to the other state types. The other state types are all dominated by lactobacillus, and they vary with respect to the specific lactobacillus species that dominates them. But this is the only one that is really dominated by anaerobes. And it's way more common among Black individuals in pregnancy and outside of pregnancy. And when I first started hearing about this, when I would hear the microbiome folks talk about it, they just kind of talked about it as if it was like, that's just the way it is. That's just how it's going to be, right? Like not going to. And I thought, really? You know, the microbiome is one of the most environmentally sensitive bits of our body, right? You take 2 doses of amoxicillin and your entire microbiome is different within a day or 2. I mean, that is an extremely sensitive aspect of our bodies. And so I thought, well, maybe something like air pollution could be contributing to that. Of note, this lactobacillus in Dr. Elevitz's cohort is associated with spontaneous preterm birth. She's not the only one who has shown this. We've known for a long time the microbiome is associated with spontaneous preterm birth. But we looked to see specifically whether Allen's predictions of air pollution for the participants in Dr. Elevitz's cohort were associated with this high-risk cervical vaginal microbiota. And indeed, we found that per standard deviation increment higher, first trimester PM 2.5, when you then collect the sample at 16 to 20 weeks was the sample we used for this analysis. So prior to this swab, we had higher risk of the high-risk cervical vaginal microbiota, the CST4. And when we restricted to Black participants, we lose a little bit of power, but in general, we're getting a very similar message. And so likely, regardless of race, air pollution may be associated with the high-risk cervical vaginal microbiota for preterm birth. Now, do we know that this is causal? No, this is observational work, right? But it's definitely hypothesis generating. And this is only one environmental exposure. Can you imagine if you took the entirety of the different environmental exposures that happen by race in this country when it comes to the jobs we do, when it comes to our maybe products that we buy, when it comes to our diets, when it comes to a zillion things, there are differences. And they're going to vary individual to individual, but at the population level, they are different and could definitely lead to population level differences in microbiome, in my opinion. So this leads to the what can possibly be done, right? And do I know the answer? No, because people have been working on this for like 50 years and haven't figured it out. But we're from a long kind of string of optimists, I think, and we want to think through ways in which we could contribute to a better outcomes for all and reducing the gaps between populations. So I have the honor to work with Gina South, who is my multi-PI partner on a study that Ayman mentioned of green space and hypertensive disorders of pregnancy and chronic hypertension. Dr. South is really a leader in this. She's also a member of the Philadelphia, I'm going to get it wrong, PRECCH, CCEH, there we go, of this group. Really because she's thought about how to improve environments, specifically using green space as a potential lever. So these are pictures from a trial that she was a part of. Dr. Branis, Charlie Branis, was her mentor. He's now chair of epidemiology at Columbia. And he did a cluster randomized control trial with his team of greening vacant lots in Philadelphia. There were 2 types of control lots. One was do nothing, and the other was clean them up. At the end of the study, all the lots got greened. Actually, the Pennsylvania Horticultural Society does this all the time on an ongoing basis, and they kind of said, stop, don't green for a few, can we plan? And they created clusters of communities in which the greening would happen. So these kind of buffers in which all of the lots in those areas would get greened, and then other matched lots that were very similar would not get greened, and they would see what happened to the folks who live nearby. So they found decreases in violent crime at the greened lots, not at the trash cleanup lots. They saw improved mental health of the folks who live nearby. And then Gina did this cool thing where she put trackers on people, which now I think we would call Fitbits or Apple Watches, but she used some other predecessor device in which she had people walk around Philadelphia. And as they were walking by green spaces, these greened lots, their heart rates came down. And so I think for those of us who hike or walk in the woods or walk in green spaces, we know the calming effects of green space, but to show that empirically really lent some validity to the scientific plausibility in the way in which green space may be helpful. There are other mechanisms that Gina will propose, Dr. South will propose, like community cohesion, meeting up, decreasing stress by social engagement. There are a lot of different ways in which green space may be helpful, but this may be a kind of a more direct cardiovascular benefit. And we worked with Max Jordan, who's a now second-year resident in internal medicine up at the Brigham in Boston. He came for a year between his third and fourth years of medical school when he was at Yale and spent the year with us at Penn. And his work really served as the basis for the R01 that Gina and I have. He was able to show that folks who had more tree canopy were at lower risk, or those with less tree canopy near their houses were at higher risk of hypertensive disorders of pregnancy. And his work was interesting in that I think a lot of this work can be confounded, and we know this, right? So maybe wealthier people or people with different habits are going to live in greener spaces. But he adjusted for a neighborhood deprivation index at a very fine scale using the Colebrook-Camp neighborhood deprivation index. Which is freely available, and I would highly recommend taking a look at it because it doesn't include race, which is really important and different from the SVI as well as the other neighborhood deprivation indices. Nonetheless, I digress. He was able to show that even when you adjust for neighborhood deprivation, you're able to see a persistent association with low tree canopy and hypertensive disorders of pregnancy. This was done in Dr. Elevitz's cohort, the one I showed you earlier. He also was able to show in those with a history of depression that green space was associated with lower perceived stress scale scores during pregnancy. And then because I told you I am interested in lots of environments, including the ones in which I work. So this is the NICU. We are running a trial because I think even the environment in which parents exist right after they give birth, even for the first few weeks or months, can affect their interaction with their baby and may even affect their health habits and may affect their between pregnancy health. We have the goal of eventually bringing, and I know that my fellow mentee, Tim Nealon, has a pilot grant in which we're going to, hand out air purifiers to some of these and monitors for individual level air pollution assessments for some of these families. But we are enrolling postpartum parents and their babies into a trial of a doula and midwife intervention, because when you have a baby in the NICU, you may not prioritize your own health care, to really set kids on a different trajectory and families on a different trajectory after they leave the NICU. And often when this is done, it's really only with maybe the medical care or psychosocial supports. But if we can add in the layer of environmental consciousness as well as potentially some environmental interventions, then I think we're going to make a bigger dent in the long-term health of these kids who are at risk. And the people who just had a baby are the people who are most likely to have the next baby in the next couple of years, right? So we know that, especially if it was their first baby. So we can see that in our data. So this is really a captive audience for several weeks. Babies that are less than 32 weeks are in our units for at least a month. And so we have an opportunity to really potentially change the way in which we interact with families, as well as set up their environments after they go home. So this is the FIFA Women's World Cup schedule in New Zealand this summer. For anyone else who will be there, I'm going. I'm very much looking forward to it, but I look forward to having a conversation with all of you and getting to know you. And please do consider reaching out if you're too shy to do so publicly today.
Thank you, Heather. This is a great and really, interesting talk for us to think about and how to handle this, health disparity and racial segregation, or actually we got a better word actually from the comments. So let me actually come up with a couple of questions from the comments first. So Haley Pio, I think she has one comment and one question. So one is a sort of language, not just residential segregation, but intentional environmental racism through redlining, I think you mentioned. And her question is, can you elaborate on why you cannot write about the concept you mentioned in a paper?
So a couple of things. So the first is that redlining happened, that particular actual redlining maps happened in the 1930s, but there is ongoing racism that leads to ongoing residential segregation when it comes to occupation, segregation in many, many aspects of life. And that can lead to or is associated with environmental racism. So I totally hear the spirit of that and I agree, but there is indeed ongoing residential segregation that sometimes, most of the time, probably has some environmental racism. But even when you look at places that have very similar environments, you often will see separation by race. So I know this from growing up in a pretty middle class Black suburb where there wasn't as much environmental racism, but there's still a fair amount of segregation. We are writing about the paper, the specific paper. I have a student who is writing the paper. Her name is Numi. She's a fourth year undergrad at Penn, and she's writing the paper about air pollution and differences in the microbiota and challenging the kind of concept of the microbiota as some innate state that is not modifiable. What you can't write, I don't think, maybe I can, but to write the word fancy biomarkers, right? That seems a little colloquial. So that's what I was really referring to, just you can tell I'm not super formal, but I need to be a little bit more formal when I'm writing. So that was really what I was getting at it. Oh, there she is. Sue says I get it.
Yeah,
okay,
that's good. And Tara Stevens has a comment. Currently, gentrification is leading to similar injustices.
Yeah, so that's wonderful. Yeah, gentrification is a hard thing well, that doesn't mean we're not going to do it. We are doing it, but it's a hard thing to, I think, quantify well. And there's some funny things that happen with gentrification that I think some of the folks on this call might be more adept at analyzing. But one of the things that can happen is you can get an acute spike. Sorry, all my kids just came home from school. You can get an acute spike in kind of in exposures because of all the renovations that happen. So sometimes you can get demolition. So we were looking at housing demolitions. You can get that data from the city, and you can get like an acute increase in exposures. One of the challenges we find, and I think it's something that Jane Clordy has seen, she's another colleague I work with at Drexel who does a lot of work in New York City, is sometimes you see paradoxical associations where in places like the Upper East Side of New York, where there's a fair amount of air pollution, but you see better birth outcomes, you can find some really spurious, weird things. So gentrification is like a kind of a hot topic for sure, and something that is going to need to be done well in order to capture, because some of these places still are not that green, but with gentrification often become green because of power and resource allocation and all of those things. But yeah, I would love to talk more offline. I'm just blabbering about it, probably in my great writing haze, but yeah, I think it's a great point.
All right, Anna Heiser has a comment and a question. So lab toxicity is a leading cause of preterm birth and preeclampsia. It's also much more common in African Americans because of the housing bias. Do you want to mention this?
Yeah, for sure. Lead is, I think one of the reasons I don't talk about lead is because I feel like lots of people know a lot about lead already. So it's not that it doesn't exist. Certainly I mentioned metals, but lead is the one we know the most about. And there are differences that persist. We were just looking at this data in Philadelphia again, that yes, there are higher levels. They're not routinely always measured in kids. We're proposing to be, in pregnant people, although that's changing. It's measured in kids, but we're proposing, I don't know if we'll get it, but we're proposing that Penn and CHOP be an echo site in which we'd get to really quantify not just lead, but all the metal mixtures, right? These things are not isolated, and they sometimes have more than just an additive effect. That comes from my being a mentee of Bob Wright, who's kind of taught me a lot about metal mixtures, but I think these things can really amplify one another and wreak havoc. So yeah, it's super important.
If I might add, there is an opportunity because the current ACOG recommendation for lead testing is completely it's completely unable to be implemented because it's so complex that what happens is obstetricians don't wind up testing for it. And that can be changed.
Yeah, that's related to translation, because this is a really translational center for children's around the house. And, this is a good point, really talking about potential translation. I think,
Hi, Heather, this is Trevor.
Poor Trevor has heard me talk a zillion times. How are you?
Great, well, I always have questions for you. So I'm wondering if you have any data on indoor air pollution. Nadia Hansel was here the other day from Hopkins and has done some very nice work on indoor air pollution and indicated that actually indoor air pollution can be worse than outdoor air pollution. And although people are advised to shut their windows if they live near traffic, they actually may be doing themselves a disadvantage. They should keep their windows open. So taking that on as a direction, do you have any data on indoor air pollution as it relates to preterm birth?
Well, so I don't have it in our local data. There's definitely data internationally, especially with lots of folks have done even trials to change cook stoves. Most of that data is around birth weight, not as much with preterm birth, but there is some data to support the improvement and lowering of preterm birth rates when you change out a cook stove to be a clean air, less air polluting cook stove. I mentioned Tim Nealon, who's in Paris right now, which is why he's not on this call. He'll be back next week, but he's a neonatology fellow whose specific interest is in the management and optimization of kids who already have lung disease from being born really early. So those kids less than 28 weeks. So this is a health equity issue too, because when you are 3 times more likely to be born less than 28 weeks, you're about 3 times more likely to have chronic lung disease of prematurity. Anyway, so he is very interested in how to optimize the environments of these kids. And so we were just pricing out, and we've been pricing out for the last few months and working on, I think he has a pilot grant from this group to monitor the indoor air quality of kids who are going home from the NICU. So really starting with a very at-risk baby. As I mentioned, though, the people who have a baby are the most likely to have another one. And so I really do think this would be an opportunity for us to look at the interpregnancy period. There are a lot of considerations that I hadn't thought through. Jane Clardy helped us think through them about, how many monitors are you planning on, getting them back? Are you planning on, bringing them back out? And I know we had worked through some of this. I can see Marilyn nodding her head a little bit when we had thought about another grant with George Girton before. But I think we're going to start small, try to do it, at least get some preliminary data, and then really think about ways in which we can look at this. I think this is also together with, for a long time, having heat has been thought of as being a human right, but air conditioning may also at this point be becoming a human right. And so thinking about public support for universal air conditioning, et cetera, is going to be really important. So it's a great point, Trevor, and one that hopefully Tim will have the bandwidth to tackle.
So the other thing is and maybe Clementina wants to comment on this, but if you're going to plan on doing heavy metal mixtures, the center does have an ICP-MS. Right?
Yes, yep.
So samples could be analyzed, but also what I've been hearing is a lot of people are interested in the idea of metabolomics right now. So actually you can actually look at isotope ratios of different metals and actually therefore determine the age at which that exposure occurred based on the isotope ratio.
Yep. And some people will do it based on other ways, right? I mean, there are folks, Manisha Aurora looks at shed teeth in order to get at the actual time of specific exposures during in utero development. So I think there are lots of ways to do that. And certainly there are challenges with metabolomic analyses. We've done some of those too. It always depends on the pipeline and how you're normalizing your data. And a lot of the same challenges with the microbiome data also exist for the metabolomic data. So I think I'm cautiously optimistic we'll be able to learn from metabolomic data, but it can be a bit daunting for some of us.
So WHO has reduced the air quality guidelines, especially PM 2.5 to 5 micron per cubic meter. And the EPA still has 12. So, and more evidence is accumulating that actually air pollution is not only causing respiratory or cardiovascular disease, but also perinatal and neurodevelopmental and child obesity issues. So in terms of children's surrounding health, is there any way to really make this a little more like lower, just like lead, we have gone through 25 to 15 to 10 to 5, now 3.5. It is the trajectory that we're thinking of, the intervention, the translation.
Yeah, I mean, I think that it's going to take political will in order to do this, and it's going to vary. I think that was the interesting thing about the PNAS paper last week or the week after before that, which is that depending on where you are, what you need to do to improve air quality varies, and certainly what you need to do in order to decrease the disparity can vary across setting. But I think we've been hearing, at least I've been hearing on NPR, that at least California is going to go to zero emission cars by 2035. And I think car manufacturers are going to be really moving in that direction. I know that's not the only source, and we have to be thinking about our power generation and other industries that are often emitting. So I think it's going to take a lot, but I worry about rollbacks. I think, there have been certain times, certain elections where I know Alan and his group went in real quick to make sure they pulled down all the data before it would disappear. So I think we need to fight for data availability. And then we need to fight for improved, lower kind of thresholds for what we consider healthy. I think you're right, Ayman.
And thank you, Heather, and thank everyone for really participating in this.